I'm going to talk with you about safe opioid prescribing in individuals with serious illness. In this presentation, I'll provide an overview of substance use disorder and the rationale for assessing for opioid misuse risk prior to prescribing opioids, discuss universal precautions for opioid prescribing, and outline some strategies for appropriate opioid prescribing for individuals with risks for opioid misuse. Substance use disorders all have similar criteria, whether it's alcohol, tobacco, opioids, stimulants, cannabis, hallucinogens. There's a compulsivity, there's a loss of control, there's social, physical, and psychological consequences. Now, physical dependence can occur when people are appropriately prescribed and taking opioids appropriately, but physical dependence in a different way when we're using the non-medical use of, for example, opioids is what we're thinking about in this instance. The risks of substance use disorder or for substance use disorder are multifactorial. Genetics may account for 50%. And then there's the environment, chaotic home, abuse, parent use and attitudes, peer influences, community attitudes, early use. And we know that people that have had adverse child experiences of 4 or more are at much greater use to develop a substance use disorder. So this is not a moral failing. This is a biologic happening. And drugs of abuse target the brain's pleasure centers. So they're rewarding substances, when we think about opioids, that activate the dopamine pathway in the brain. And this dopamine activity decreases during withdrawal. You think about when you eat something pleasurable like a donut and you get that sugar rush, which is that surge of dopamine during pleasure, and then it withdraws. Now, if you don't have an eating disorder, you may not feel the need to go back and get like another donut. Same way with medications or drugs, is that if you do not have a propensity to develop a substance use disorder, you may take an opioid and not get that. While that dopamine surge may be there, you will not have that feeling of withdrawal with the need to actually use it again, or the craver. It's for those that are susceptible to the development of misuse. And this chronic use actually causes changes leading to decreased reward from the same amount of drug. And when you talk with people who have developed a substance use disorder, it becomes this binge intoxication, withdrawal, and the craving again for that reward, and then the binge intoxication and withdrawal without the reward being part of the circle anymore. And there's that constant craving for that type of feeling again. So what is the scope of substance use disorder in the palliative care or with people with serious illness setting? Well, there's few studies that are in the oncology population, although more and more are emerging. But in the studies, we've seen that the risks for opioid use disorder are similar to risks in populations with chronic non-malignant or non-cancer pain. In some studies that were conducted using the screener and opioid assessment for people with pain revised version, one with over 500 patients with cancer-related pain, it was seen to be like 29% were at high risk to develop aberrant behavior or opioid misuse. And the reported risk factors were younger age, higher pain intensity, more symptoms of anxiety and depression, and on higher doses of opioids. In another study of patients with cancer seen in an emergency department, 34% were considered high risk of misuse. Again, we see higher pain intensity, poor coping, depression, and then illicit substance use as risks. Using a different tool, the opioid risk tool, and looking at over 100 patients with cancer in a palliative clinic, 43% were medium to high risk. And Of the 40% that had urine drug screens, almost half had abnormal screens, meaning potentially what was supposed to be in the urine was not, or that there might have been evidence of non-medical use of substances. In another clinic with cancer and sickle cell disease, 25% were seen at high risk. In an institution where I worked, we did a pilot using the opioid risk tool in the thoracic head and neck oncology clinic, and of the 40 patients that were screened over a 2-month period, 30% were moderate to high risk. And in a larger study done at the institution, of 226% patients screened, 15% were at moderate risk and 13% were at high risk. So again, really mirroring the results that we see. So the bottom line is that there may be not any difference, or in some cases with certain type of cancers, a higher risk for the development of opioid misuse. And so therefore, how do we safely treat patients potentially with opioids and not cause any further harm by potentially inducing a iatrogenic opioid use disorder? So when opioid therapy is a consideration, we want to consider adopting a safe opioid prescribing practice. Now, there's no guidelines at this moment that exist in palliative care. However, the guidelines can be extrapolated from the universal precautions for opioid prescribing that were originally used in chronic pain management. The use of guidelines may identify patients at risk for substance misuse and actually allow for an early intervention. Universal precautions for opioid prescribing were originally utilized in chronic pain management, and all patients are treated as if they're at risk for opioid misuse, because this is an effective strategy as clinicians may not always identify at-risk individuals. It reduces stigma about labeling an individual as at risk. And I know in my own practice, one of the first patients that I identified was someone who actually was not misusing the opioid herself. She's a 74-year-old woman with advanced pancreatic cancer, but actually it was being diverted to her family member. So this is a busy slide on looking at components of universal precautions, some that were first outlined by Gourlay and Haidt, who had developed it for chronic pain management, and then looking at some of the practices from or recommendations from the National Comprehensive Cancer Network. And it really starts with really a comprehensive pain assessment and a differential diagnosis for the pain, which we should be doing for everyone, not just assuming just because someone has cancer that, automatically we should be treating with opioids because they have pain. And really making sure that we have clear documentation of the treatment plan, decision-making, and goals, and ongoing reassessment of the analgesic effect. So really the key assessments, is to do a comprehensive pain assessment. Is this neuropathic? Is this nociceptive pain? Is it inflammatory? Is it acute? Is it chronic? What is the reason for the pain? Is it because of tumor burden? Is it because of nerve compression? Is it the effect of chemotherapy causing peripheral neuropathy or aromatase inhibitors causing severe arthralgias? What about the substance use history? Does this patient have a family history of substance use disorder, including alcohol, current alcohol use, current recreational drug use? Because remember, when we're thinking about substance use, alcohol is the most frequently used substance. What's the living situation like? Is there teenagers, children, young adults? What are the support systems in the house? And then we want to look at key considerations is that are there past or current use of opioids? What medications, what duration, what's the efficacy? Have there been collaboration with previous providers? Have we been checking the prescription drug monitoring program to see what else is being prescribed? And again, as we talked about before, really clearly documenting our goals and reassessment. So another consideration in universal precautions is our opioid risk assessment. So risk assessment is just one component of utilizing universal precautions. And there's not a tool that's been validated in those with serious illness, but there is recommendations to potentially use either the opioid risk tool or the screening for opioid assessment for people in pain. The opioid risk tool is used to predict which individuals are more likely to develop aberrant behaviors. It was originally validated with only 185 people, but in this, 94% of those that were low risk did not develop aberrancies, whereas 90% of high risk did. The tool was revised and they eliminated the pre-adolescent sexual abuse question. They unweighted the responses between male and female and really simplified it. And in this, the predictor of risk for the development of opioid use disorder had a sensitivity of 85 and a specificity of 85, odds ratio of 3.085. And so this is the tool. And really, a lot of this should be coming right in your assessment. Is there a family history of substance abuse, alcohol, illegal drugs, prescription drugs? Is there a personal history? Alcohol, illegal drugs. Is that person between 16 and 45? Does this person have psychological diseases such as attention deficit, obsessive compulsive, bipolar, depression? And really, a score of 2 or lower indicates a low risk for the development of opioid use disorder, and greater than 3 is a high risk. Now, please note this was part of a secondary study and it was only validated in the Caucasian population, but I think we can extrapolate to say more than likely it's not secondary to ethnicity. That would be changes in risk. So possible aberrant behaviors that may be associated with misuse risk. If someone self-escalates their opioid doses, they lose their opioids, they are borrowing from family and friends, there's pill count discrepancies, or you see multiple providers, or you start seeing a significant change in function, like a decrease in function, and you don't see a progression of disease. So when you take your clinical interview and your risk assessment, you can stratify and you establish a level of risk based on all of this together, not just the opioid risk tool. And really, your level of risk determines your frequency of follow-ups, your use of pill counts, frequency of random urine drug screens. There's no established guideline, but there are multiple suggested strategies. And this is one that we use in our own clinic, where we do the clinical assessment that the patient's likely to have therapeutic opioid behavior, and that their SOAP score was less than 9 or their ORT revised was less than 2 or less, and the morphine equivalent doses are less than 100. Moving into moderate risk is someone who has more than 100 milligrams of morphine equivalent daily, just because we know from the literature that risk for adverse effects increases with the dose of opioids. Someone who has an opioid risk score of 3 or greater, and that you have done a clinical assessment and the person is at higher risk. And the high risk is where the clinical assessment is the person is at high risk for misuse of opioids and your ORT is greater than 3. So examples of this a risk stratification in action that we use in our own clinic is that all patients will have an initial urine drug screen and sign a patient-provider agreement. The prescription drug monitoring program is checked prior to each controlled substance prescription, and moderate to high-risk patients will have increased frequency of visits, and this may even be weekly, even if with a nurse visit, pill counts, random urine drug screens, and that frequency is really determined by the prescriber. So when we think about informed consent and patient-provider agreements, an informed consent really outlines the risks and benefits of opioid therapy, that there is a risk for adverse events, there's a risk for the development of iatrogenic opioid use disorder. And even though the experts recommend the use of these agreements, there's really not great evidence looking at the efficacy in terms of reducing misuse and abuse. However, I find for my own practice it's a really helpful education tool. So what's in a patient-provider agreement? Again, you see I'm not using the word contract. That really should be avoided. So it's the expectations for the benefits and adverse events associated with the opioid or controlled substance. Designating one pharmacy for filling a prescription may be part of the practice, although these days with a lot of pharmacies potentially not carrying the medication needed, then you may have to use other pharmacies. The importance of using one prescriber or team, and the importance of taking the opioid as prescribed, and what are the consequences if you deviate from the established prescriptions. The frequency that prescription will be filled, compliance monitoring, how to safeguard your opioids, why and how to discontinue opioids, and then all should have a place for your date and signature. And really, it should be written at the literacy level of the patient population. This is a sample of one that we published in the Journal of Hospice and Palliative Nursing well over a decade ago, but it was trying to show how we tried to reduce the literacy level to what we felt that our population was at that point. And there are ways that when you are writing or creating these documents that you can check the literacy level. What about the use of urine drug screening? So urine drug testing is one of the only objective measures to see if the patient is taking what's being prescribed and to evaluate for the presence of illicit drugs or medications that haven't been prescribed. So there's, again, not great evidence that this will actually decrease misuse. It's one way of really looking at, is the patient taking what we're prescribing? And realize that some insurances may not cover the costs, and hospice programs may need to absorb costs if you're using it in hospice. Now we have the rapid turnaround. This is the dipstick urine. So it won't pick up things like oxycodone, it won't pick up fentanyl unless your rapid test in your institution actually is designed to do that, like pick up things like oxycodone and fentanyl. But it can really pick up things like, is there cocaine, is there benzodiazepines? Again, it really depends on the test that you use, and it's important to know what this will actually show. The gas chromatography mass spectrometry is high sensitivity, and so this will detect your individual drugs and their metabolites. And this is really recommended for use when opioid is prescribed. So, for example, if that patient is taking oxycodone, we should see oxymorphone, potentially noroxymorphone, as the metabolite. If you only saw the oxycodone, that meant the patient really didn't take it, probably just dipped it into the urine because it's not metabolized. Same way when you see buprenorphine, you should see norbuprenorphine as a metabolite. Now, some other things we're going to talk about that are really part of this is your prescription drug monitoring programs, your opioid reversal prescriptions, patient education, and medication disposal. So your prescription drug monitoring programs, all states now have prescription drug monitoring programs, but the programs are state specific and really different in accessibility and functionality. Some collaborate and report multiple surrounding states data. We have that in our own. I think it reports for like 9 different states that we can look at. And there's some data that show that the programs may decrease abuse or misuse because you're identifying what medicines your patient is getting. In certain states, the use of a prescription drug monitoring program is mandatory prior to prescribing opioids. And there's some data that shows some changing in prescribing patterns in these states. Now, remember, federal opioid treatment programs, this is where your patient goes for methadone maintenance, where some patients may actually even obtain buprenorphine in these programs, even though it can be prescribed in a clinician office. They do not have to report the dispensing of the methadone or buprenorphine. Electronic prescribing may improve tracking, obviously decrease the risk of prescription forgery. It's mandated in a certain state and likely to increase over time. I haven't written a physical prescription and probably I can't even remember the last time I wrote one. Um, so probably close to a decade. One important thing is to think about opioid reversal. I think that every person that's prescribed an opioid should have naloxone. And we should really prescribe it for all patients who are on high dose opioids, which the CDC indicates a greater than 50 milligrams of morphine equivalent daily. Those that are at risk for overdose, those that are frail, have organ dysfunction, those that already have a substance use disorder, or if there's safety risks in home, meaning young adults, teenagers, children. And patients should be educated about medication disposal, and storage. And so really when we're thinking about safe use, naloxone, locked at home, and how to dispose. Now, many of the product inserts will say to flush in the toilet. Others will just say that we shouldn't be even thinking about that. There are some counseling documents online. So let's move into some general opioid prescribing guidelines. So there's no significant difference in pain control side effects response in a study that was done when they compared morphine, oxycodone, fentanyl, and buprenorphine for chronic cancer pain. So really, there's individual variation in the response to the agent. And so one day, hopefully, when we can actually do testing, we might find that different people respond differently to opioids because there's many different opioid subtypes. And a lot of times the selection of one over another is really based on clinical judgment, formulary access, cost, and the availability of a parental formulation. Now remember, mu agonist opioids trigger that dopaminergic reward system, and it can produce euphoria through binding, and so therefore the activation of this reward system can trigger craving and possible misuse. So when we think about our immediate release opioids, it's a faster onset increase in blood levels, can trigger that reward system, whereas the use of an extended release opioid or long-acting formulation potentially decreases the reward or the likability component. If you have concerns for misuse, you might want to use an abuse deterrent extended release opioid formulation. And there are several of them that are available. You may have challenges in terms of authorizations, although some state programs actually have that on their preferred medication list. You want to minimize the use of breakthrough medications. If a patient's really requiring more than 4 doses of opioids daily, then we really need to increase the extended release opioid. You want to think about buprenorphine products, low dose that are FDA approved, high dose for opioid use disorder can be used off-label for pain. You want a complete documentation of your plan that's accessed by your team, especially if you're off. Because if you are refilling an opioid without a visit, you want to document well. What's the pain? What's the need? What's the risk assessment? Check PDMP. You may want to use specific instructions on the time of medication administration. For example, 8 a.m., 4 p.m. versus 8-hour dosing, just to minimize confusion. And for those with breakthrough pain who require the use of immediate release opioids, you may be necessary to make medication time contingent or related to a painful activity versus relying on pain severity as an indicator. You want to create a safe treatment plan for those individuals with repeated dose escalations. They should be assessed for potential reasons. Is there inefficacy of the opioid? Possibility of misuse or diversion. And use of non-opioid adjuvants should be part of your management plan because escalating doses of opioids may not always adequately address the pain. And you want to really document a detailed plan to ensure consistency in the cases where there may be cross coverage. So in follow-up assessment, you want to observe for aberrant behavior. Have there been emergency rooms visits for pain without changes in pathology? Have there been unsanctioned opioid dose escalation? Have there been early prescription refill requests or evidence of multiple prescribers? So frequent visits may be necessary to assess for the appropriate use of prescribed medications, and this may include the use of urine drug screens when indicated. Dispensing a limited supply of opioids may be necessary for those patients that are high risk, and when appropriate, engaging friends or family to help ensure compliance. Again, you have to be careful if you have someone who is at risk or does have opioid use disorder to ensure that the people in their environment are also not involved in the same practices. You want to make sure that the medications are safely secured in lockboxes to prevent diversion. And for some individuals at very high risk for opioid misuse, you might want to even consider daily visits if the person is on hospice, which is something that we have done in the past. There are tools that can help to detect changes in risk status and the need for more frequent visits and monitoring. One is the current opioid misuse measure, and this can detect challenges with opioid use once a patient is started on opioids. I prefer to use something that was developed originally by Dr. Steve Pasek, which is the pain assessment documentation tool, which assesses for analgesia, activity, adverse effects, and aberrant behavior. But the most important reassessment is your clinical interview, your objective measures such as urine drug screen, and the prescription drug monitoring program check. Other things to consider are the use of a pain diary, where someone actually tracks the self-reported use of medications, and the use of pill counts to ensure the patient brings all the medications to each visit and may need to adjust, obviously, if the patient's taking public transport. And in this era of telehealth, it may also be challenging, so you may have to rely on your prescription drug monitoring program. In this slide, you will see an example of an opioid management workflow that I adapted and used with permission from Dr. Seddon Savage, which really outlines some of the things that we've talked about, really starting out with that comprehensive pain assessment, really looking at the goals, co-prescribing nasal naloxone. And if you're inheriting a patient on opioid therapy, discuss plans for possible rotation, tapering, or discontinuing of opioids. You want to monitor for improvement in function and analgesia, aberrant behaviors, and you revise care as indicated. If we have negative outcomes and no progress toward goals, unmanageable side effects, persistent risk behaviors, consider taper and discontinuation or transition to medications for opioid use disorder. If positive outcomes, you really progress toward goals, you're not having any unmanageable side effects, no persistent risk behaviors, you consider opioid continuation and periodic trial tapers. And this is someone who has stable disease, for example, or no evidence of disease. Now, in terms of opioid reversal, 47 states and the DC have Good Samaritan and naloxone access laws, so I can actually go in to the pharmacy and get a prescription for naloxone. The laws vary among states, but there is some evidence of decreased opioid-related deaths when compared prior to the laws. And it's really available, like I said, to lay persons in most states. And we really should make sure that someone is providing education to caregivers how to administer naloxone in the event of an overdose. Again, we talked about safe drug disposal or the use of the Drug Enforcement Agency take-back programs. Hospice settings should have their own policies for proper medication disposal, and and this can happen when we rotate to another opioid before the previous opioid supply is finished or on the patient's death. So really the take-home points is really to utilize universal precautions for opioid prescribing with all patients that you are prescribing opioids, and create an opioid management workflow that is sustainable in your work setting.